If you said B, prepare for transfusion, you are correct. This patient does need IV PPI therapy and an urgent intervention, whether endoscopy, surgery, or IR embolization, but most urgently they need volume repletion and transfusion for hemodynamic instability and brisk bleeding. The management of GI bleeding varies depending on where it's coming from and what causes it. Upper GI bleeding is bleeding anywhere from the esophagus to the ligament of Treitz, which is a landmark that distinguishes the duodenum from the jejunum. Small bowel or colonic bleeding, or lower GI bleeding, occurs anywhere from the ligament of Treitz to the anus. Upper GI bleeding is associated with hematemesis, or vomiting blood or coffee ground-like material from clotted blood, and melena, maroon or black stool, from old and partially digested blood. Very brisk upper GI bleeding can cause hematochezia, or bright red blood in the stool, if the bleeding is very brisk and the blood moves very quickly through the GI tract. Patients with upper GI bleeding can have an elevated BUN to creatinine ratio from increased digestion of hemoglobin from the blood in the GI tract. A BUN to creatinine ratio greater than 30 has a positive likelihood ratio of 7 for an upper GI bleed. Small bowel or colonic bleeding typically presents with hematochezia and clots in the stool. Blood can be mixed in with the stool, dripping into the bowl, or just seen on the toilet tissue when wiping. When assessing a patient with GI bleeding from any source, the first step is to assess their stability with their vital signs, mental status, and volume status, and triage them as either stable or unstable. Orthostatic vital signs can be a useful tool to assess volume status. Patients should be prepared for the need for rapid volume resuscitation with 2 large bore peripheral IVs as soon as possible for plenty of vascular access, and should have a type and screen and CBC done to prepare for the need for transfusion. Transfusion is indicated if the hemoglobin is less than 7, or if you suspect a very brisk bleed that will cause their hemoglobin to drop very rapidly, as if you wait, you may not be able to catch up to the bleeding. People with chest pain concerning for angina or ACS also have a higher threshold for transfusion in order to prevent myocardial ischemia. In this case, the transfusion threshold is a hemoglobin of 9. Patients who are on blood thinners like aspirin and clopidogrel, heparin, warfarin, or a DOAC may need reversal of their anticoagulation or blood products like prothrombin complex concentrate, cryoprecipitate, or platelets to help them clot. Blood thinners and NSAIDs should be held, and high-dose IV PPI therapy should be given to all patients while you work out if they have an upper or a lower GI bleed, as increasing gastric pH can help promote mucosal clotting. Gastroenterology should be consulted for all patients to assess for the need and urgency of endoscopy. The cause of upper GI bleeding can be diagnosed by upper endoscopy. Esophageal causes of bleeding can include esophagitis, esophageal ulcers, and esophageal varices, Borhave syndrome, or a complete esophageal rupture caused by severe straining while vomiting, or an esophageal malignancy. Protracted nausea and vomiting can also cause a Mallory-Weiss tear in the esophageal mucosa without complete rupture. Typically presents with vomiting that turns bright red after several episodes. Gastric causes can include peptic ulcer disease, gastric varices, malignancy, and gastric arteriovenous malformations, or AVMs. Duodenal bleeds can be caused by peptic ulcer disease, malignancy, AVMs, or rarely an aortoenteric fistula, or a hole between the aorta and the duodenum, which can cause very fast, life-threatening bleeding. Ideally, patients with variceal bleeding should undergo endoscopy within 12 hours and non-variceal bleeding within 24 hours. Brisk or life-threatening bleeding from any cause needs more emergent evaluation. Peptic ulcer disease is one of the most common causes of upper GI bleeding and is characterized by ulcers in the stomach or duodenum which erode through the mucosa into the muscularis. Symptoms include upper abdominal or epigastric pain, bloating, fullness, and early satiety. Pain from gastric ulcers often increases with food because of increased gastric acid production, whereas pain from duodenal ulcers improves with eating but worsens when the stomach is empty because the food acts as a temporary buffer against the acid production. Alarm symptoms include new onset dyspepsia over the age of 50, weight loss, melena, and iron deficiency anemia, as these are concerning for very severe ulcers or malignancy. Infection with the bacterium Helicobacter pylori, or H. pylori, can cause around half of all cases of peptic ulcer disease. Chronic infection can increase the risk for gastric adenocarcinoma or gastric lymphoma, or maltoma. It can be diagnosed by observation of bacteria on biopsy samples taken during endoscopy. It can also be diagnosed using the H. pylori stool antigen test or the urease breath test, both of which are 90 to 95% sensitive for H. pylori infection. First-line treatment is what we call bismuth quadruple therapy, which includes 14 days of bismuth subsalicylate, metronidazole, tetracycline, and a high-dose oral PPI. Unfortunately, antimicrobial resistance is becoming more common in H. pylori, so the risk of treatment failure or relapse is high. Patients should be tested again 4 weeks after finishing therapy to ensure they are cured. Variceal bleeds often need more urgent endoscopy than bleeding from other causes, and after endoscopy, these patients should be closely monitored for rebleeding and for hepatic encephalopathy. Patients with cirrhosis who have had no prior history of variceal bleeding should undergo endoscopy every 1 to 3 years to screen for varices. If patients have advanced cirrhosis and a small varices or any degree of cirrhosis and medium to large varices, they should be started on non-selective beta blocker or undergo serial endoscopic banding to prevent bleeding. If a patient has already had a variceal bleed, they should be offered both beta blockers and endoscopic banding to prevent rebleeding. Now that we've talked about upper GI bleeding, let's try some questions.